Volume of distribution, VD. The mystery of drug levels. A patient receives an intravenous drug, but its plasma concentration is surprisingly low because the drug rapidly enters the tissues. Another drug given in the same dose produces a high plasma concentration because it remains mainly in the bloodstream. Why this difference? The answer lies in volume of distribution, or VD. Defining volume of distribution. Volume of distribution is the apparent volume in which a drug would need to be distributed to produce the observed plasma concentration. Volume of distribution is equal to the amount of drug in the body divided by the plasma drug concentration. It is not a real anatomical volume. It is a mathematical concept reflecting how extensively a drug spreads through the body. Worked example: calculating VD. Using the definition of volume of distribution, we can calculate VD when given the dose and plasma concentration. Volume of distribution is equal to the amount of drug in the body divided by the plasma drug concentration. Suppose amount of drug in the body is 500 milligrams. Its plasma drug concentration is found to be 10 milligrams per liter. Substituting the known values in the formula, volume of distribution equals 500 milligrams divided by 10 milligrams per liter. So, the volume of distribution is 50 liters. Interpreting VD values. Now, let us interpret different VD values. A low VD, around 3 to 5 liters, means the drug stays mainly in the blood or plasma. This is typical of large molecules or highly protein-bound drugs, such as heparin. A medium VD, around 10 to 20 liters, suggests distribution into the extracellular fluid and is commonly seen with small, hydrophilic molecules. A high VD, greater than 40 liters, means the drug has extensively left the bloodstream and distributed into tissues, fat, or muscle. Thus, the higher the VD, the greater the extent of tissue distribution. Factors affecting VD. Several factors can alter the volume of distribution of a drug. First, body composition is important. Higher body fat increases VD for lipophilic drugs because more drug can accumulate in adipose tissue. Second, plasma protein binding reduces VD. Strong binding to albumin keeps the drug within the bloodstream. In contrast, tissue binding pulls the drug out of the blood and therefore increases VD. Finally, age and disease can alter body fluid compartments. Conditions such as dehydration, kidney failure, or edema can therefore significantly shift drug distribution and change the VD. Clinical significance. Volume of distribution has three important clinical applications. First, loading dose. VD helps determine the dose required to rapidly achieve the target plasma concentration. Therefore, a drug with a larger VD generally requires a larger loading dose. Second, dialysis effectiveness. Drugs with a high VD are difficult to remove by hemodialysis because most of the drug is sequestered in tissues rather than circulating in the blood. Finally, half-life. A larger VD is generally associated with a longer half-life because the drug must redistribute from tissues back into the bloodstream before it can be eliminated. Key takeaways. To summarize the key takeaways, remember that VD is an apparent, not anatomical volume. It is a mathematical value reflecting how extensively a drug distributes in the body. A low VD means the drug stays mainly in the blood, whereas a high VD indicates greater entry into tissues. Protein binding and lipophilicity are important determinants of this distribution. Clinically, VD helps guide dosing, dialysis, and half-life predictions, making it an important concept for safe and effective use of drugs. Common Viva questions. Before we finish, try answering these two commonly asked Viva questions on volume of distribution. 1. Can the volume of distribution be greater than the total body volume? If yes, why? 2. Why are drugs with a high VD poorly removed by hemodialysis?